Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Welcome to this podcast on CAR-T therapy for acute lymphocytic leukemia in children, ALL. I have the pleasure to have here with me today Professor Concetta Quintarelli. Welcome, Professor Quintarelli.
Nice to be here.
Can you please introduce yourself?
Sure. I am professor in hematology, working in Italy in the University of Naples, and I'm based in a pediatric hospital, Ospedale Pediatrico Bambino Gesù in Rome, and head of the unit for development of CAR-T therapy and general gene therapy for tumors. And also we have a GMP facility for production of academic product and the unit of immunomonitoring of patients after the infusion.
Okay, to start softly for our listeners, what is ALL and how does it present in children?
So ALL is an acute leukemia that is appearing as an explosion in our patients, especially in the bone marrow of a progenitor of a B cell. And this is associated with the complete issue in the hematologic system, hematopoietic system, because it's an imbalance between progenitor cells, that are tumor cells, and the normal compartment. And this is all the hematologic issue that the patients had at the diagnosis of the leukemia.
So the first child that was treated with CAR-T therapy, Emily Whitehead, was treated for ALL. She had tried all available therapies and she had relapsed, and she was trying as a last option CAR-T. But this was now more than 10 years ago. So she was cured by all accounts until the moment. What happens now with children that come to you with ALL? Is CAR-T still the last option? How do you treat these patients when they have just have the diagnosis of ALL?
So since the initial development of CAR-T, many improvements in the system has been obtained, and this is very lucky for our patients. Indeed, of course, when the new therapy is entering in clinical trial, we are imposed ethically not to use in patients that have other options. So Emily, as many other patients at the beginning, they were treated in their fourth or fifth line of therapy. And this was ending in high difficulties for CAR-T then to be effective to completely eliminate the tumors, because chemotherapy and relapse of the disease is changing completely the microenvironment in our patients. But we saw in clinical trials after the first trying to use CAR-T, that early is the line in which CAR-T is used, better is the outcome of our patients. And this is also the reason why even the commercial product, they were all developed after the third line, but now they are also approved for the second line. And in the context of pediatric ALL, actually, Professor Locatelli in Europe will start a clinical trial very soon, trying to use CAR-T cell therapy against CD19 in first line. So for patients with very high risk, so it's a subgroup of ALL patients that has very bad prognosis, because all the patients are relapsing even after transplantation. We will try to use in first line CAR CD19 therapy. And this will be an European trial to be soon opened.
So the intention when you treat with CAR-T is to cure patients. In what proportion is this happening for children with ALL?
Of course, to speak about cure, we need to wait a long-term outcome. And we have data mature for long-term outcome for pediatric ALL, because this was the first indication in which CAR-T has been developed. And the data now are very clear, showing that 30% of patients receiving CAR-T are cured because the leukemia didn't recur after 5 years from the CAR-T treatment. But we are really looking forward to modify this percentage, because we really need to increase the outcome, and we think that bringing the therapy early on in the patients will improve the outcome for them.
So this is a very harsh treatment for a child, with many steps and with chemotherapy to prepare them for receiving the cells. Are there any developments to make this treatment less harsh for them, or less long, and maybe not have to treat them with such strong chemotherapy agents?
So actually, the hardest for our children is before the CAR-T treatment, because the high-dose chemotherapy is given before to prepare the patients not only for CAR-T, but to induce a reduction of the tumor burden. Mm-hmm. Then the chemo that we use for the lymphodepletion has not so high side effect as the standard high-dose chemotherapy that usually the patients are receiving. Maybe we can replace that. So we can replace the high-dose chemotherapy that usually pediatric patients receive with CAR-T, and then consolidate with transplantation the patients after the CAR-T. But this schema right now has not been used. We have many immunotherapy. We have not only CAR-T. So, for example, the BiTE. So we should develop a schema in which, for example, patients are induced to have a low tumor burden, low minimal residual disease by the use of immunotherapy as the BiTE, and then consolidate with the CAR-T, and in case the patients will be not cured completely, then to go to the transplantation. But this is just hypothesis. There is no clinical trial proving that we can replace the standard chemotherapy in first consolidation and then go to the CAR-T. And this is, for example, the trial that we want to start in Europe soon.
So this trial for first-line therapy in children. So will lymphodepletion be in this trial done with BiTEs?
So the first clinical trials on CAR-T have been developed without the lymphodepletion and been used for many clinical trials, but it's very clear the association between the need of lymphodepletion to obtain the expansion of the CAR-T. So the lymphodepletion is helping the system in the patients to be prepared, because we are eliminating the T cells. So there is lymphodepletion because you eliminate T cells and B cells in patient compartment, but actually is also the myeloid cells that often reduce the activity of the CAR-T. So the lymphodepletion is preparing the patients to receive the CAR-T, because the bone marrow that is cleared by the lymphodepletion is starting to produce many factors as a cytokine. They are then helping the CAR-T to expand when they are infused. And many clinical trials has just demonstrated that the lymphodepletion is almost mandatory in these patients to obtain. But your questions can be also read in another way. Is this the only lymphodepletion regimen that we can use for them? So right now there is no attempt to modify it. For all the commercial product or the academic product, the lymphodepletion, especially in patients, are pretty standard. But some groups are working to understand if it's possible to modify this regimen. Right now, actually, what we do for ALL in pediatric patients are just applying to all the other indication, also in the adult one. And with the development of new CAR-T product for new indication, clinical trial trying to understand if it's possible to modify the lymphodepletion regimen based and designing them on the specific tumor or leukemia or lymphoma that the patient has.
What about the toxicities? We know about short-term toxicities, and they are being managed better because now there is more experience. But about long-term toxicities, there is a lot of talk about the fact that in some cases CAR-T can itself induce secondary malignancies. This is particularly relevant for children who are getting this treatment really early in life. To what extent malignancies are caused by the CAR-T treatment, and what can be done to reduce this risk for children in ALL?
So thank you for these questions, because in a hot questions on this, and regulators are evaluating this year about these secondary malignancies because they were reported in patients treated with the CAR-T. But basically we need to see what is the reality on that, because even without CAR-T, patients that are treated for leukemia with the high-dose chemotherapy, with the radiation, they tend to develop secondary malignancy. Unfortunately, it's been reported forever. And if you look the percentage of patients treated with CAR-T and then generating secondary malignancies compared to patients that never received the CAR-T, actually the percentages are just the same. If you ask me, can we improve the safety of the product? Of course, the answer is yes, especially working on targeting in our DNA the integration of the CAR construct in specific locus to avoid an insertion in any other proto-oncogene. Some groups are working for that. The manufacturing is a little bit more complicated with respect to the standard of the production, but many groups are working for that. Also, biotech, just to increase the safety, as you just said. But secondary malignancies, in my opinion, will anyway come in the patients. But we should, modify completely the treatment of these patients to avoid the occurrence of secondary malignancies. But right now, the situation for me is not hampering any issue with the CAR-T use. It's just the setting in which we are using them.
Is there anything else that you would like to add for the audience?
So, in the field of CAR-T, especially for the pediatric population, it's not an easy field in which to invest, either for academic center and also for pediatric, because we are speaking about rare disease, and we don't have specific support for that. We should have more attention on the need of the pediatric population because, for example, the biotech compartment, of course, is going where the market is larger. So pediatric population with rare disease is a very difficult setting in which to work. And this is the reason why the academic center working for pediatric patients and try to do a network. But a regulatory point of view is very difficult to understand how a network can really collaborate to use CAR-T, because we need to share patient samples, we need to share products, and there is like a world that needs to be built. We are in this position, but it's difficult. So what I want to share with who wants, hear our words is that working for new immunotherapy for pediatric patients has a lot of issues, but the clinician knows how we need to do that, and the European commits really are trying to help us for the development, but the academia can go up to one certain level. But then we need to have a support from biotech to bring our product that we develop for patients to a next level to be spread to all of them.
There is a big issue of cost. Then we all know that CAR-T is a very expensive treatment, and it has been trying to be reduced by academic centers producing their own CAR-Ts. But what you're saying is that you need anyway to bring biotech into this to get it better distributed, or
we need an innovation in the system in which are, because it is a reality. The centralized manufacturing is the system that we have now. And of course, the biotech has used this system because regulators are already, already in that. They know how to evaluate dossier for centralized manufacturing. And of course, the company has used this path because there was the only one. But now there is the attempt to stay on the table with regulators and biotech and academia to understand if it's possible to improve the system and to render the system feasible for a larger number of patients. And the point of care, so the production at each nation can help the system, but it is an innovation, not only because you need to have manufacturing center in each nation, but also because we need to understand a regulatory point of view how this system can be then approved for a market authorization. There is no other product on the market that can be used as a scheme, yes, as a prototype. We need really to invent something here.
Yeah, especially because at the end of the day, each product is different because it's personalized. It comes from the patient cells that are modified, and in each case, it's a very specific way of producing a medicine. So I imagine that the agencies are having a new case to work on to see how to get this to a patient, but to take care of safety, efficacy, and okay. Thank you very much, Professor Quintarelli, for sharing your knowledge with us, and thank you all for listening.
Thank you for this very nice interview.